Nationally, if you look at orthopedics as a service line, it's predominantly an outpatient service. For us, it's predominantly inpatient with about 2.5 million discharges per year, at least in 2009. And although you've been told that the incidence of hip fractures is going to go up and that you're going to do a lot more based on population estimates, those who are in the know really think that the number of hip fractures that will be treated over the next decade, as well as upper extremities in a hospital setting, will likely go down. And that may be from improved osteoporosis management and number of just risk and safety factors. However, upper and lower extremity fracture management on an ambulatory basis is predicted to increase. Orthopedics is a big service line in the healthcare industry, and we're going to see increasing competition with a lot of our trauma and fracture services going downstream. By going downstream, I mean that other specialties, non-orthopedists, will likely pick up and provide those services for our patients. Most likely the more minor procedures, the minimal or non-operative fracture care, dislocation care, and sports injuries. It's a significant cost center for payers and the feds, and the focus will be on value, and they are defining value as quality divided by costs over time. So they're going to put into effect cost controls. You already see that. From a trauma perspective, trauma will become more systematized. There are federal incentives for states to develop trauma systems. Trauma networks result in triage. Triage will eventually have pretty defined criteria, and those centers treating increased volumes will be able, hopefully, to prove increased value because they are you, and I trust you to provide high quality and decrease costs over time. However, there'll be pressure from other competitors to retain patients locally, especially with PPAC and healthcare reform as the number of self-pays diminish. Centers will be designated likely on volumes and their outcomes, and the result will be increasing leverage for those who are working in the higher level centers, but with that will come accountability. So at the hospital level, I think you'll see the orthopedic trauma services evolve to more specialization as there becomes concentration within these level 1 and level 2 centers. We already see now balkanization or separate hand and spine fracture services, and likely you'll see some of these other services breaking off from having general orthopedists or general trauma orthopedists providing all services around the skeleton. You'll also see increasing what's called vertical integration, and that's going to do to payment reforms and cost pressures. And vertical integration is where hospitals are aligning with physicians and even maybe with payers. There will be a performance pressure, and with that will come transparency and public reporting. CMS is leading that already and already reporting quality measures for hospitals and outcomes, and you're going to see probably in the next 3 or 4 years costs, your charges, as well as payment becoming more and more public. The healthcare market is then hence becoming more efficient in terms of macroeconomics, and you already see report cards being out there for hospitals and reporting never events, for example, and now eventually it's going to providers. Payers are already profiling providers and providing them with report cards on their services compared to their peers. What will happen is that will become public in the next 3 years, I predict. And if I look up any of your names on probably any of these social networking sites, you're evaluated by the public already. And I would challenge you to put your name in any of these, and you, especially if you do have an elective practice law, you'll find that you're rated by the populace already. So public reporting from social network sites is coming into prevalence. The only thing that hasn't happened, I challenge your healthcare systems to do it, is put out payer report cards. They're being done internally by these systems, hospital physician systems, but they aren't yet being published on the web. The focus of the government as well as payers and patients will be on quality. You know about the variation of services in orthopedics, and the government as well as payers and the populace is going to focus on unnecessary treatments and procedures because of the perceived unnecessary expenditures. Appropriate use criteria will be coming forward. The Academy is becoming involved in this and will develop them in a number of fields. And that's because doctors determine what care is medically necessary. However, there's a paucity of data, at least good evidence-based data, on what is appropriate, inappropriate. There's a lot of our costs are believed to be driven by innovation and technology, but again, there's little data to support that. As you know, variation in orthopedics needs to be diminished. These are hip fractures on the left, which appears to have a little variation compared to other procedures further on to the right. However, in fracture surgery, now you compare hips to other treatments for regional variation of fracture surgery, you can see we're all over the board. And so that's perceived to show that the appropriateness of these types of surgical procedures, there may be some inappropriateness there. You're seeing vertical integration first in the payer market with mergers and acquisitions. Payers are consolidating. That gives them increased market share and control, increased political capital, and hence the influence they had on the PPACA legislation. They're the big systems you all know out there, and those represent the major payers and over 90% of the healthcare insurance market, those handful. Hospitals are also aggregating the systems, so you no longer have single hospitals, but you have hospital systems. Orthopedic surgeons have aggregated or vertically integrated in groups. This has become a threat to payers because that gives them increased capital and market clout, and have developed competing services such as specialty hospitals, ASCs, ancillary service lines, and this has definitely challenged the American Hospital Association and payers, hence the moratorium on specialty hospitals. There will be payment incentives, as have already occurred, from payers to providers. They will tier providers based on what they're going to call quality of care. They'll use things such as, do you adhere to evidence-based practice? They'll look at your procedure volumes and costs for specific services, your use of EMRs and registries, your mortality rates and complication rates, and obviously some of these are already reported publicly for hospitals. Though the patients have the same incentives, they want to decrease their out-of-pocket costs as well as increase the quality of their care. The future, I believe, will be, said by those going to lead HHS and CMS, is that payment will no longer be based on volumes, or at least disproportionately. It will be based more on process and outcome measures. PQRI is sort of the antecedent to that. Value-based purchasing was out there in 2009, and in 2011, things are going to be based on your safety, readmissions, and outcomes. And I think that's only going to become more prevalent in the future. Transparency and public reporting, both for your outcomes, but also for prices, reimbursements, results, and quality, as well as safety. And the result is increased competition for level 1, level 2 trauma centers, especially if there's more than one trauma hospital in the region. These are all pressures to vertically integrate, meaning you're seeing a huge increase in the number of physicians that are becoming employed. The Academy runs a census every 2 to 3 years, and about 5 or 6 years ago, about 5% of physicians were hospital employees, 7% the last census, and I believe it's going to be 10% this year. There are several models of employment or affiliation, the medical staff model, contractual relationships such as joint ventures, equity relationships, and obviously direct employment. And collaboration and or integration will become mandatory in order to participate in the reporting and reimbursement system. And these are the potential things that are out there now. In the future, PPACA mandates the development of accountable care organizations, or ACOs. 4 different types of practice or business models for physicians will qualify. That's sort of the integrated delivery system, the multi-specialty group. The onesies and twosies and solo practitioners are going to have a hard time integrating. There are physician hospital organizations and IPAs. And the 3 tiers to qualify for ACO designations are fee-for-service with shared savings, which will be rebated for quality, less than your expenditure targets. These are all linked to different payment reimbursement formats and incorporate a different level of risk and reward. The second level is bundled payments and episodic care payments, so one payment shared between your hospital and physicians. That's already being demonstrated for reconstructive procedures such as joints. And then the highest level, where you assume the greatest risk to your organization, but also has the potential for the greatest benefit, is partial or global capitation. So in summary, I believe that in the future, our populace will see increased access to medical care, mostly through increased coverage, healthcare coverage. There's going to be an increase in government role, which will set the standards by which most other payers will eventually follow. This will be tied to payments. Patient responsibility for their services is going to continue to increase in terms of both the dollars, cost sharing, and decision-making processes because of public information on the web for those who have access to that. Reimbursement will be linked to your own accountability and the accountability of the system in which you practice. Right now, those will be process measures, such as did or didn't you give antibiotics preoperatively, and eventually it'll be performance measures, which are more based on outcomes. So there's huge pressures for vertical integration. Most trauma surgeons do have sort of hospital affiliations that may be tightly linked, like at Harborview, or more loosely linked. That's in part because the infrastructure costs that all physicians are going to see in order to do the reporting that will be required for reimbursement and quality outcomes. And in order to practice in a systems type approach, vertical integration is here. Thank you very much.
Our next speaker is Jim Hughes, who carries a very large set of illustrious titles, but the ones that we're most proud of is a former visiting professor at Harborview and lifelong friend of Dr. Hansen. Dr. Hughes is going to talk to us about no longer being a secondary citizen within the hospital. Thank you, Jim.
Thank you. Thank you for the privilege of coming home. We all know these things that are so apparent to us. We've heard it all day. So I'm going to go through this very, very quickly. But I want to build a case on this very subjective lecture that we know that more than half of the patients admitted to trauma centers have musculoskeletal injuries. And the volume of patients that come with civilian fractures, and it's one of the leading causes of death and obviously impairment in trauma cases. So immediately we have our first establishment. We have the volume and we have the patients to designate orthopedic traumatology as a true primary tier specialty. Hospital administration sees this. You know, there was a confluence of events that occurred not too long ago. And that is when all of our arthroscopy colleagues, our sports medicine friends decided they want to take their little fancy instruments and go into their private little hospitals and begin to take care of their patients. And they've done a beautiful job with it. It's not to negate it at all. About that time, M.D.M.B.A came down the pike. And M.D.M.B.A says, okay, hospital administration, you now are responsible for trauma. That came in light of diffusing out of a lot of orthopedic surgeons that could have and should have and probably did have training in fracture care. So 75% of the patients with blunt trauma and 90% of the patients with multiple injuries have some type of bony injury. 50% of all surgical cases at shock trauma are orthopedics. So in that consideration, the hospital administration says we recognize the need, especially for trauma centers. That's been covered. We have recognition of positive outcomes with our patients. We're going to give them bed allocation. We're going to give them some OR time. We're going to give resource allocations such spaces, equipment, etc. And we're going to release some financial resources because now we are responsible. And then we'd look at towards the war situation. He who desires to practice surgery must go to war. It's also been quoted in 2009 that he who desires to go to war must first learn war surgery. I learned my war surgery at Roosevelt Hospital in New York City for 2 years as a general surgeon before I went to Vietnam, and I'm thankful for that particular exposure. But now we do find that the volumes of patients associated in the wars that we're fighting, 66% of them have surgical procedures performed during wartime or orthopedic, with general surgeries comprising only 21% as the next closest specialty. What about literature? 97% of the articles in the Journal of Orthopaedic Trauma were generated at an institution with a designated trauma department. In the Journal of Trauma, Injury, Infection, and Critical Care, several issues and I calculated 40% of the original articles in this very diverse journal had to do with those considerations of orthopedic traumatology. 45% of the case reports and 50% of the review articles were based on orthopedic traumatology. So the literature is supporting the fact that this is no longer a second-tier specialty. What about education? The orthopedic residency requirements. Our residents must understand these principles for the OIT and board questions. The fellowships, but there are 23 ACGME accredited university-based orthopedic programs. There are 40, but now there's many more positions per year, so there are places for our young people to be trained. The hundreds of seminars that are given throughout the world, national, international courses, and the CME availables all support the knowledge base that needs to be disseminated associated with this consideration. What about specialty organizations with required training in orthopedic traumatology? Certainly Tim has shared with us as the leader of the OTA, the AO Foundation. These organizations are organized specialists for the sole purpose of increasing the knowledge base and the dissemination of that knowledge and professional intercourse between people who would share the knowledge with each other. The publications of the American College of Surgeons states that a Trauma One center, the requirements for an orthopedic traumatologist should be ABOS certified, medical staff membership, CME trauma meetings, attendance of certain percentages of orthopedic traumatology specialty meetings, quality and assurance programs in the hospital, attend the trauma morbidity and mortality, and assist in the trauma center verification. So this person, the orthopedic traumatologist, is an integral part of the Trauma One Center. What about outcomes? All of us that have been in Switzerland recognize that Martin Allgauer told us that motion is life and life is motion. Certainly the ORIF versus immobilization, a quicker return to work. We have the damage control orthopedics, regardless of how you debate it, it is still a part of the thought processes that go on in our daily care of patients. What should we do? When should we do it? And how should we do it? And the intra-articular fractures, obviously, as many have shared today, you must have them correctly with reduction, alignment, and stability. So, where are we in all of this? The volume of patients, is that an affirmative for us in our subjective evaluation that we have no longer a second-tier specialty? The answer is yes. What about the hospital administration? The answer is yes, that's an affirmative. Referral-based, that's an affirmative. What about the industrial focus? That's an affirmative for us. What about research? That's an affirmative for us. What about literature? That's an affirmative for us. What about education? That's an affirmative for us. And what about organizations? That's an affirmative for us. And what about outcomes? That's an affirmative for us. So you see that the orthopedic traumatologist is now a primary specialty in the United States. In the field of dreams, they said if you build it, they will come. We can say they have come. So the specialty of orthopedic traumatology has been built. Disclosures? None, but guess what? Through admiration of each of you who have built the specialty of orthopedic traumatology, I am 100% biased.
Thank you very much. Our final podium presentation is Jim Kellam, also Harborview ACE. Going to talk to about the looking forward, the next 50 years of the AO Foundation.
Thanks very much, Sam. I've been asked, and you guys are all here, to talk about the next 50 years of the AO. Now, I'm biased because I'm not an immediate past president like Paul. I'm a past president of the FIAS. I'm completely biased. So when I talk about the foundation, I'll try to give you an idea of what it is and perhaps where it's going in the future. Remember in 1958 at this hotel in Bienne, Switzerland, these 13 individuals got together and at that time created an organization which was known as an Arbeitsgemeinschaft. Well, an Arbeitsgemeinschaft simply means it's a fellowship of friends who are put together with a purpose in life. Okay. Their purpose was to improve fracture care. Now this is an important basis to remember on why the foundation is where the foundation is and what it means to many of us and why I think it is so important and will continue, as did Ted Hansen as well. In 1984, Allgauer and Mueller realized that the foundation, or AO as at that time, needed to be salted into something else to make sure it continued. And at that time, they created what is now known as the AO Foundation. Well, the AO Foundation is a medically guided, non-profit organization led by a group of international surgeons who are specialized in the treatment of basically trauma and disorders of the musculoskeletal system, and it consists of craniomaxillofacial surgeons, as you see by Paul, spine surgeons, Jen Chapman is into it in a big way, vets, and what we call general trauma or fracture surgeons. Its mission in 2010 basically is to improve the treatment of patients. It's a patient-centered organization, believe it or not. We are there to improve care in patients by trying to improve our care in the musculoskeletal system. It's now done through 5 basic ways, and I'll try to go through these and give you an idea of how in the future 50 years they may be appearing. Now you have to realize this can't be done without money, okay? And there is money and there's a financial support to it. And the foundation now runs off an endowment, which is an attempt to make it more independent, but at the same time has cooperation agreements with industrial partners on a contract basis to provide goods and services for them, which tends to make this a much more workable organization. But remember, it is an organization run by surgeons for surgeons, and so that everything is done in it is done on a surgical basis. And its success has been based on the fact that we have common goals, we have this collegial spirit, importantly, a worldwide network, and a desire to improve care. Well, in 2060, which is 50 years from now, I will not be here, so I'll never know what I'm going to tell you is going to make it, but some of you may. Will it exist? What will it look like? And what will it do? Well, I believe it will exist, and I believe that it will exist as a worldwide independent knowledge organization, which will try to provide a consensus-based education, research, and innovative development for disease in the musculoskeletal system. And the reason I believe this is because of its worldwide network and the reason it was developed. It will be a strong network of regional and specialty groups, and this is in the process now within this organization of trying to figure out how this is all going to work. It will have with this group, the individual specialties, as you've seen, and the various regional groups. AO North America, a very strong group, which has been one of Ted's he was one of the founders of it and a special place in his heart for it. And the foundation will also be central. And the foundation's function in this will be a common platform for its specialties and for its regional organizations to have consensus strategy and funding worldwide. Membership will probably, any surgeon out there who wants to join, who meets what are called basically some form of defined expertise by their specialties. And hopefully in 50 years, the financing of this will be totally self-dependent, so it can be a transparent group to all, offering the benefits of the foundation to anybody who wishes it. So it will be recognized as an unbiased scientific organization which will provide quality surgical oversight and development and innovative technology to the international community. Well, let's look about what it might look like. Research in the organization has been a major focus of it for years, and we have had research in Davos, and it has always been strong, it's peer-reviewed, it has tremendous impact factors and prediction of papers. The problem with it is it's too unfocused, and we are now trying to focus this. What I believe in the future will be is the AO research will be fairly well-defined, but more importantly, it will work as a coordinator of research networks. Research nowadays in what we do in basic science can't be done by individuals. It has to be done on a network basis with people coming together to be able to achieve what they want, to talk to each other. And this is one way the foundation can do it. It will continue to look at exploratory research that is in essence off the wall and that sort of thing, but that'll be a minor point, and this will be where its funding is. So in essence, we will have the AO research, but we will cooperate and collaborate with a whole group of other people trying to improve what is going on in biotechnology, which will become its major focus. We are developing a very strong clinical research department in the foundation, and I think this is a very important aspect because what this will hopefully, I think, do is provide an international evidence-based group of individuals for research. It will have a central function that it can manage worldwide clinical research networks. Hopefully, we will be able to train people, okay? Mark's talked about outcome research, but where do you get training to do this? How do you do this? This organization may be able to provide that to you, may be able to come up with some method of certification for these things, and hopefully lead the way in this area, as well as collaboration with various other things. REDCap is the Vanderbilt program of documentation, which we are now using, and as time goes by, the interaction, again, of our clinical research with others. And more importantly, with our technical system, this whole thing of cost effectiveness of what our implants are. This becomes imperative with an organization like this, that perhaps we can do this, and this is where we will have the strongest force, is trying to come up with what is effective. As well, we can get large databases that you can make things, and perhaps looking at artificial intelligence with care and many other different aspects of where we're going. AO education, a major area. The foundation has become leaders in the assessment of continuing medical education, believe it or not. It has done many studies looking at that, and I think it will continue to play in that role. Electronic learning is the way of the future. None of us are going to come to meetings very often anymore. We're going to be more and more looking at our computers. And the foundation, I think, has the opportunity to look more and more into this and create distant learning opportunities, bringing its network of surgeons together, bringing its experts together to do this. It will also, I think, move into the maintenance of competence. You can be able to come up with programs, databases that you may be able to use, demonstrate how you're doing these things, and worldwide this is going to become greater and greater around the world. And it will all have to be done on a regional basis. And this is just what it might look like. AO Spine is running a worldwide global conference. AO North America has a meeting that's coming up shortly that is well sponsored by many individuals looking at fracture care across many specialties. Our technical system is one of the highlights. This is the old TK system that many of you may have known. It's changing. It's becoming much more of an organization to try to come up with new ideas and try to come up with the cost effectiveness of treating. It is a nice system because it puts a bunch of doctors together to look at something. It's surgeon driven, and there's no bias and there's no conflicts in this system at times. So effective treatment, appropriately based, and hopefully available to any party who wishes to take part of this in the future. So in 2060, the AO Foundation will continue to be medically guided, nonprofit organization led by a bunch of international surgeons. Hopefully many of you will think about joining and become part of it. It's been a great time from my point of view. It'll have some new priorities and goals, but hopefully it will still provide quality research development and education in musculoskeletal disease and trauma. And I thank you all for sitting here for so long to listen to me. Thank you.